It's been a global effort, and we're now starting to see the fruits of our rewards. No drugs for 50 years, and then in the last 3 to 4 years, we've had 3 drugs approved.
The challenge we know from the past is to find that sweet spot where you have maximal albuminuria reduction and minimal side effects.
It's really nearly astounding because this is really what we say we want to do for our patients is lock in their GFR, keep them absolutely stable.
Welcome to the ASN Kidney Translation podcast. In this special episode, we're covering the late-breaking clinical trials simultaneously published in JASN here at ASN Kidney Week 2024 in San Diego, California. I'm your host, Dr. Matthew Sparks, a nephrologist at Duke University and communications editor for the ASN portfolio of journals, JASN, Kidney 360, and CJASN. Our goal is to provide you with insights from the latest advances in kidney medicine and foster discussions on how these breakthroughs will directly influence patient care. Today, we'll be speaking with authors of 3 late-breaking clinical trials, all presented at ASN Kidney Week 2024 and simultaneously published in JASN. These studies focus on innovative treatments for IgA nephropathy, an area seeing rapid advancements thanks to redefined surrogate outcomes championed by the ASN Kidney Health Initiative. We'll explore therapies involving complement inhibition, endothelin blockade, and novel approaches to reduce immunoglobulin class switching aimed at reducing galactose-deficient IgA. Our first guest is Dr. John Barrett. Dr. Barrett, could you please introduce yourself?
Yeah, thanks, Matt. I'm John Barrett. I'm a professor of renal medicine at the University of Leicester in the UK.
Well, first, congratulations to you and your team on publishing the phase 2 Sanctuary study. This is simultaneously published in JASN during ASN Kidney Week. We're really excited about that. The title is Efficacy and Safety of Ravulizumab in IgA Nephropathy. Before we get started, can you mention any conflicts of interest that you have with this study?
Yeah, so I'm on the steering committee of the phase 2 and also on the steering committee. In fact, I co-chair the steering committee for the phase 3 ICAN trial, which is of ravulizumab in IgA nephropathy. And I work with Alexion to help design and deliver these clinical trials.
Well, first things first, wow, IgA nephropathy. It seems every time you open up a journal, you go to the late-breaking clinical trials and they're everywhere. Why is that? Why are we seeing this plethora of drugs that are being used to treat IgA nephropathy?
Well, Matt, I think we have a perfect storm. When we first started, a global community of nephrologists who were desperate to have new therapies to treat IgA nephropathy. We had a regulatory landscape, thanks really to the Kidney Health Initiative in the United States, that collaboration between the ASN and the FDA, that re-looked at endpoints for clinical trials in IgA and agreed that we could look at an early change in proteinuria, making clinical trials easier to deliver in a rare kidney disease. And we had a patient community that were desperate to get involved in clinical trials. So we had a change in the regulatory landscape, nephrologists and patients desperate for new therapies. And we've really delivered on all fronts globally in terms of getting our patients into clinical trials in an unprecedented manner, and even in the setting of a COVID pandemic. So what we've seen is nephrologists roll their sleeves up from Argentina in South America through to Beijing, through to Japan, through to across Europe, across the United States. It's been a global effort, and we're now starting to see the fruits of our rewards. No drugs for 50 years, and then in the last 3 to 4 years, we've had 3 drugs approved, probably another one before Christmas, and I would envisage new drugs being approved every year for the next 3 to 5 years. So we are going to have a big job on our hands working out how to use these drugs, but a good job.
That's exactly right. I mean, we have been really clamoring for some ability to treat these patients. And let's talk about this drug, ravulizumab. And it's, I guess, I call it maybe a sibling of eculizumab, very similar, longer half-life. We here in the United States also know it as one of the most expensive drugs that you can give. Obviously, when you look at the biopsy of IgA, you see immune complex deposition. So we know that complement is part of the pathway. However, I think it's becoming a little bit of a surprise to see that, wow, we've had eculizumab for well over a decade. And if you go through the literature, you see a smattering of case reports. Can you talk a little bit about kind of how this study started and what we know about the pathophysiology of IgA nephropathy that led to this study?
Yeah, I mean, we've always known since really the first description of IgA nephropathy in 1968 that there's co-deposition of C3 in over 95% of cases. And there's a lot of data from blood and urine studies and kidney biopsy studies that activation of the complement pathway is one of the main drivers for glomerular injury in this disease. And so it's not been surprising that we would want to look at complement inhibition as a way of controlling that glomerular response to immune complex deposition. And you're right, there were some early case studies of eculizumab, but when you look at those, these were kind of like the last gasp treatment for people doing very, very badly. So they didn't really give us a true idea of what a complement inhibitor could deliver for us in the setting of giving it in early on in the disease. And I think what we've seen is that complement inhibition is capable of causing significant reductions in proteinuria and really meaningful impacts in early outcomes in IgA nephropathy. And that's what I think the phase 2 study that we're talking about can show us. And the good news is, of course, we've used ravulizumab for a long time, so we know its safety track record, we know how to use it, we know what to look out for, we know the precautions we need to take. And the other thing I just want to mention is we focus a lot on glomerular inflammation as the way the complement inhibitors are working. But there is, in fact, a lot of really interesting data that complement activation is important in driving tubulointerstitial inflammation and fibrosis. And actually, one of the interesting questions is how much of the effect that we're going to see with complement inhibitors is due to inhibiting glomerular inflammation, and how much over the longer term is due to the fact that it's actually protecting the tubular interstitium from the effect of proteinuria. Because it may be that it actually is a drug that could be very useful in any form of proteinuric kidney disease. And that, of course, raises a whole new set of questions in terms of where we might use it. But I think what's great about the clinical trials is we're collecting biomarker samples and we can ask those questions. But I think complement inhibition is here to stay, and I think we're going to use it more and more in the treatment of IgA nephropathy.
Well, let's talk about the study now. And just the first question I have is why ravulizumab over eculizumab? What was the rationale for that decision?
Well, I think ravulizumab has a longer half-life. We're dealing with young people who want to get on with their lives, and actually impacting as infrequently as possible with intravenous infusions is much more meaningful for a young person who doesn't want to take time off work, may have childcare responsibilities, wants to really get on with their life and not be tied to coming in for regular infusions. And I think the data from atypical HUS and PNH really speak to the safety and acceptability of ravulizumab as an easier way to deliver C5 inhibition. So it made sense. Why would we go backwards with a more frequent infusion when we can go forwards with an infusion that is less onerous on the patients?
Do you think that if and when this ever gets approved, that insurance companies will allow revolution first line over eculizumab?
Now, that's a question I guess will be dependent on where you live in the world, to be quite honest. And I live in the UK, so we have a very different system to the US. So I would expect if a strong argument can be made for efficacy, safety, and patient acceptability, then certainly that's something that I think payers should look at in terms of what's best for the patient. But that's going to be a nice problem to have if we've got a phase 3 trial that shows that ravulizumab is safe and effective in IgA. I'd much rather be in that situation than not even be able to consider it as a potential treatment choice.
Completely agree. Let's talk about the sanctuary study. Can you tell us a little bit about the study design?
Yeah, so this was a phase 2 study looking at ravulizumab compared to placebo, and then a crossover where all patients who received placebo also got ravulizumab, and there was an open label extension. So we have data in a placebo control setting for the initial part of the study, and then all patients on ravulizumab. And the beauty of that is that you can actually see the difference between placebo and ravulizumab, and then you can see the impact of starting ravulizumab in those patients who were originally on placebo. And you can see very clearly the impact of complement inhibition. And you look at, and what we measured was proteinuria change. And of course, we looked at GFR, but this is a relatively short term study. And therefore, looking at GFR, we just need to caveat with it being not a 2-year study, but a much shorter term of follow-up. But the proteinuria data, I think, is the data that stands out. The rapidity of the reduction in proteinuria, which in my view reflects the rapidity in which glomerular inflammation is being switched off, and the sustainability of that proteinuria response, and the safety profile that we saw in the trial.
So, can you give the listeners a little bit of an idea about what exactly the goals are for a phase 2 trial?
So the goals for a phase 2 trial are essentially looking at safety and getting an indication of drug efficacy. But they're not designed to get a drug approved. They're not large enough to do that. They're not long enough to do that. So, really, it's about looking at the ability to give the drug to the patient population in question. Are there any obvious safety concerns in that population? And are we seeing enough signal from an efficacy perspective to justify a larger, far more expensive phase 3 study? And I think Sanctuary really fulfills all of those goals for ravulizumab. The safety profile is clearly no different to what we knew about ravulizumab previously. The efficacy we see in terms of the quite marked reduction, prompt reduction in proteinuria is very reassuring because we know how good proteinuria changes are at predicting long-term kidney outcomes. And as I say, while we don't have long-term GFR data in the sense of what a phase 3 study can deliver in terms of a 2-year outcome, what we see in terms of GFR is at least supportive of the concept that those changes in proteinuria will translate, if we had run the study for long enough, into a meaningful protection of GFR.
Well, let's talk about who you enrolled in the study. What were the eligibility criteria and how you ensured safety? Obviously, we know from history of use of this drug, you need vaccination for meningococcal infections. So tell us about the patients and who was enrolled in this study.
Yes, so we picked patients who were at higher risk of progression. So they had to have significant levels of proteinuria. They had to have a relatively preserved GFR. We don't want people coming in with advanced stages of kidney disease. And we clearly didn't want anyone who had an active infection. So we tried to limit any potential issues of toxicity by having inclusion exclusion criteria to exclude those patients who may be at risk. So, of course, as you say, everyone had to be appropriately vaccinated. They had to have a GFR above 30. They had to have significant proteinuria to highlight them as being at high risk of progression. And therefore, it was clinically appropriate to include them in a phase 2 trial of an experimental therapy. And of course, we want people at higher risk of progression so that actually we can show a meaningful impact over a relatively short period of time. Because, of course, if we just recruited in very low risk patients, nothing much is going to change over 48 weeks, 52 weeks. So we're not really going to know whether the drug works. What we actually need to recruit, particularly in a short-term phase 2 study, are those people where things are actually going to happen over 48 weeks so we can show the impact of a drug. And so the phase 2 trial, certainly the Sanctuary trial, specifically chose patients where we predicted that we had significant proteinuria that we could impact upon, and where there may well be meaningful changes in GFR over a relatively short period of time, so we could start to get an idea of whether the ravulizumab would protect against that loss in kidney function. And that's really true of the phase 3. So what we would generally do in a phase 2 is have inclusion-exclusion criteria that, as far as we could, would be identical to the phase 3. So we know we can translate the findings of a phase 2 study into a phase 3 in terms of the assumptions made about the sample size and the safety.
What did you do in terms of use of RAS inhibition, SGLT2 inhibitors, and immunosuppression like steroids?
So all patients had to be treated according to the KDIGO guidelines, which was they had to be on maximal tolerated RAS inhibition and still have persistent proteinuria that met the inclusion criteria. We did not allow in people who were on active immunosuppression, in particular steroids, in part because that complicates the interpretation of proteinuria, but also we didn't want to compound any potential safety signal because we know systemic steroids are associated with an increased risk of infection. So the kind of criteria that we used were patients on a stable, optimized dose of RAS inhibition with good blood pressure control, not on active immunosuppression. If patients were on an SGLT2 inhibitor, then they were allowed in, but only if their dose was stable. And we didn't want patients having SGLT2 inhibitors or other drugs started during the clinical trial, because that will confound any change in proteinuria that we see. So we were very clear about those indications. What we're seeing now in clinical trials is more and more and more patients are coming in already on an SGLT2 inhibitor. And so it's acceptable to come in on an SGLT2 inhibitor, just not acceptable to start one after you've been randomized, because it interferes with our ability to interpret the proteinuria changes.
So it looks like this was a 2-to-1 randomization of the active drug, ravulizumab, versus placebo. 43 patients got the ravulizumab, 23 patients got the placebo. Can you talk about where these patients came from and a little bit about table one, any differences that you saw between these groups and kind of what the average type of patient that was enrolled in the trial looked like?
Yeah, so for me, these are very typical IgA nephropathy patients that are recruited into phase 2 and phase 3 clinical trials. If you were to compare the characteristics against the other studies that have recently been reported, you will realize when you look at the inclusion exclusion criteria, they're almost identical for all the studies. And so you can see the mean GFRs, the mean proteinurias, the sex distribution, the mean age, the mean time from biopsy are all very, very similar. And so for me, I think the patient population recruited to Sanctuary were very typical of a high risk IgA nephropathy population. And for me, the reassuring thing is that means I can translate the kind of findings I'm seeing in Sanctuary with the findings I've seen in other phase 2 and phase 3 studies.
In what countries was this performed in?
The study is a predominantly non-Asian study, and we do know that Asian patients clearly have far more IgA nephropathy and actually far more glomerular inflammation than Caucasians. But I think in terms of what we're seeing, the data is highly representative of the populations in which the drug was studied in terms of the response we're seeing. And of course, the phase 3 is a global study. And I'm already attending investigator meetings in different continents for the ICANN study, because it's really identified we must have a global population in a phase 3 study. A phase 2 study, for practical reasons, needs to have smaller numbers of sites, it needs to recruit quickly, and may well not have the global reach that you would need for a phase 3.
And just a little bit about the patients, just looking at this, like their average age was in their 40s. Interestingly enough, this was not typically newly diagnosed. The median years of having the disease was 1 to 2, and their EGFRs were fairly preserved, average about 76 or so for the patients. So
Yeah, so what we've seen, interestingly, if you track the history of trials in IgA nephropathy, the time from biopsy has got shorter and shorter and shorter. And what that reflects is the fact that we've saturated the pool of prevalent patients for all the early trials. And as we're recruiting more patients to newer trials, we are going for the more newly diagnosed. And so this is entirely typical. If you did a timeline of the clinical trials, there would almost be a linear relationship between time the study opened and the time from biopsy, in that it's getting shorter and shorter.
and I also want to just point out that looks like about 20% were on SGLT2 inhibitors, and all of them were on ACE or ARB.
Yeah, and that's reflective of the time that the study was. We're seeing SGLT2 inhibitor use increase and increase. And so studies that have started recruiting since Sanctuary, we're now seeing 50-60% of people coming in on an SGLT2. It was just a sign of the times when we recruited those patients that was a kind of penetration of SGLT2 inhibitors.
Well, great. Let's move on to the primary outcome. What did you show?
So what we showed was a significant difference in proteinuria reduction with ravulizumab during the double-blind period. And what we showed at the open-label extension was those patients initially treated with placebo had a drop in proteinuria that was highly reflective of the initial fall we saw in that double-blind period. So for the primary outcome, we saw a very clear, significant reduction in proteinuria.
Looking at figure 4, which looks at the UPCR on every one of the study visits, you see that there's a nice reduction that occurs probably around week 4 or so and is persistent throughout the study period. And there's also an extension phase where you basically gave the placebo patients ravulizumab. Is that correct?
That's right. So there was an extension phase for all patients, and so that was the first time the placebo randomized patients received ravulizumab. So we could see the impact after exposure to placebo in those patients.
If I'm looking at this correctly, you're looking at probably an average UPCR of about 1.5 grams per gram. in the placebo group. And then if you look at the patients that receive the ravulizumab, it's down to around 1. How will that translate to outcomes down the line?
So if we look at the relationship between proteinuria and outcomes, we know there's a very clear relationship in terms of the higher the degree of proteinuria, the worse the outcome. If we also look at the magnitude of reduction in proteinuria, there is a clear relationship between the magnitude of reduction in proteinuria and the reduced risk of a subsequent kidney event 3 to 5 years later. And that was the work that Leslie Inca did and published some 4 years ago or so. And that was the basis for the FDA accepting proteinuria as a reasonably likely surrogate. So we know the higher the level of proteinuria, the greater the risk of kidney failure and the faster the rate of loss of kidney function. And the greater the reduction in proteinuria we achieve with a therapy, the greater the kidney function protection we see 3 to 5 years later.
And let's move now on to EGFR. And now, as a nephrologist, with this new criteria from the FDA, we're all becoming more familiar with slope EGFR. Can you tell us a little bit about what was found with slope EGFR with the use of ravulizumab?
Yeah, so exactly as you might expect, if we're capable of reducing proteinuria, we slow the rate of loss of kidney function. So that was really very rewarding to see. But of course, we've got to really remember here that to reliably assess GFR, we need 2 years of data. So while I'm excited about the data, and I think it's really reassuring that we're seeing a slowing in the loss of kidney function with complement inhibition that matches the proteinuria reduction we're seeing, we always need to remember it's relatively small numbers over a relatively short period of time.
And I do see where the figure actually states this is an exploratory endpoint.
Yeah, we need to be clear. We don't want to over exaggerate the meaning of this, but clearly it is very rewarding because as nephrologists, the thing we want to see is a stable or very slow decline in GFR because that's what puts people on dialysis. So we need to see that data, but we need to understand the limitations.
The one thing to note here is that in the placebo group, you do have a slope eGFR that looks like somewhere around 4 to 6. And I think that's also important to note because if you look at, for instance, the placebo group in the STOP IgA trial, if I remember correctly, it was only 1. And that to me shows that it's probably not a very high risk enough population. This seems like it was, given the placebo group was well above that.
Yeah, that placebo rate of loss is entirely consistent with the phase 3 trials that we're seeing. 5 to 6 mils per minute per year in a high risk IgA population treated only with optimized RAS blockade.
And so when you're finding patients, and if you find a lot of patients that only have a slope decline of 1, probably not going to find a big effect in a drug for a randomized controlled trial. Would that be correct?
Well, you won't find it in small numbers of patients followed for 2 years. You'd need a much, much bigger group of patients followed possibly for a decade to
Maybe
show
a
a difference.
decade, right?
Yeah, that's the challenge.
That's the
But of course, in
challenge.
trials, we want to do things quickly over a 2 year period.
Well, the other really important part of any phase 2 trial is the adverse events and safety outcomes. Can you talk about those? And especially this is important for this drug.
No, absolutely. So we have a good understanding of the potential risks with C5 inhibition in terms of encapsulated bacterial infections, which is why we make sure patients are immunized. We saw no encapsulated organism infections, and we saw no safety signal that was anything unexpected from what we know about ravulizumab already. And that's perhaps not surprising because we didn't use any additional immunosuppression in this study. We used ravulizumab in exactly the same way that it's being used in other indications, and there was nothing that we saw that was unusual for an IgA nephropathy population.
Well, that is really good to hear and also important to follow for the phase 3 trial. Well, first off, congratulations. This opens up a new era. We already have one drug that has the conditional FDA approval, iptacopan, which is a factor B inhibitor. And now we're seeing data for other complement inhibitors. And you already told us that the phase 3 trial is called ICANN. Is that correct?
That is right. Yep, the phase 3 global trial is open and recruiting, and we are shortly to open in Leicester, in my own hospital. But there's already sites open, and it's in full swing.
The last question I have is when I'm thinking about how we're going to use this drug, and I know this is a complicated question because the way the randomized controlled trials were used. Do you see complement inhibition being used almost like induction therapy, where you might see the patient and say, hey, we're going to give them RAS inhibition, SGLT2 inhibitors, background therapy, maybe endothelin blockade as well. And then potentially give steroids or budesonide. And then while doing that, have a brief period of complement inhibition. Or, and I think this is the more challenging thing, is this going to be a very long term therapy, which to me, you start to have a risk benefit discussion about being on complement inhibition for the rest of someone's life, for instance. So, how do you see it being used in the care of a patient with IgA nephropathy?
I think that's a great question. And I'm not so sure. I think to control glomerular inflammation, we would want to use it as an induction therapy for sure, in combination with a B cell directed therapy, just like we would think about ANCA vasculitis and lupus nephritis, an anti inflammatory approach combined with a treatment that targets pathogenic IgA production. But as I mentioned earlier, we think complement has a significant role outside of the glomerulus. And that's an area of active research. And if we get convincing evidence that blocking complement slows the rate of loss of nephrons through inhibiting tubular interstitial inflammation and fibrosis, then actually it could be a longer term therapy because it's adding value to all those general CKD treatments. And of course, we do have flares of IgA nephropathy. They're not as obvious as lupus and vasculitis, but I think there certainly is a role for complement inhibition in induction, and there may well be a role for chronic complement inhibition in terms of not targeting the glomerulus here, but targeting downstream tubular interstitial inflammation. So the great thing is we're going to learn about this drug as we do the trial, and that will inform how we use this long term. But at the moment, I think the future is very bright for complement inhibition in IgA nephropathy.
Well, thank you so much for your time, and congratulations to you and your team on bringing this phase 2 trial to ASN Kidney Week and for your simultaneous publication in JASN. Thank you so much for joining us today.
Fantastic. Great to talk to you, Matt. Bye-bye.
I'm joined by Dr. Guido Heerspink, who's from Netherlands, and we're going to talk about a paper that will be simultaneously published in JASN and presented at ASN Kidney Week. The title of the paper is The Selective Endothelin Receptor Antagonist SC0062 in IgA Nephropathy, a randomized double-blind placebo-controlled clinical trial. So welcome, Guido. Really happy to have you here. Can you introduce yourself briefly?
Thank you, Matthew, for having me today. My name is Guido Heerspink. I'm a clinical trialist based at the University Medical Center in Groningen in the Netherlands.
Well, fantastic. Well, IgA is having a renaissance right now. And not only that, is also the endothelin system are starting to become new options, especially for IgA nephropathy. We saw the approval, now I think complete approval of sparsentan, which is a combined ETA and angiotensin receptor blocker. Let's first just start with the basics. What is SC0062?
It's still the code name of the drug, and it tells you already that this drug is in relatively early stage of development. It's a selective endothelin type A receptor antagonist with a very high selectivity for the endothelin type A receptor. As you know, there are two endothelin receptors, endothelin A and endothelin B. From animal studies, we know that specifically targeting the A receptor will lead to kidney protection, whereas the endothelin B receptor is involved in the clearance of endothelin 1, and blocking the endothelin B receptor can also lead to fluid retention, which in the past has led to edema and heart failure in patients who were treated with relatively non-selective endothelin receptor antagonists, and these patients had diabetic kidney disease, so they were prone for developing fluid retention. That's why this drug is specifically targeted towards the endothelin A receptor.
Well, before we move on, I just want to also ask, do you have any conflicts of interest with this paper?
I am consultant to the company that is developing this drug. It's BioCity Pharmaceuticals, and I work with a number of other pharmaceutical companies together to develop other endothelin receptor antagonists.
So let's move back to the drug SC0062. We'll just call it 62 for short on the rest of this podcast. You mentioned the selectivity for ETA compared to ETB. Can you kind of quantify that if you look at drugs like sparsentan or atrasentan? How does it fit in with the selectivity to those two drugs?
Yeah, those selectivity assays are always done in experimental work, and it's very difficult to compare different experiments and the different selectivities that are calculated through different experiments. So the selectivity of 6.2 is directly compared with atrasentan, and was found that it is more selective for endothelin A than atrasentan is. And atrasentan is already selective. So this drug has even a higher selectivity for the type A receptor. And then the question, of course, is how will that then lead to fewer fluid retention, less edema, if atrasentan already has such a high selectivity? And that can only be answered by dedicated clinical trials. I think that you can do fantastic experimental work, but in the end, we are treating humans. And so the ultimate clinical trials will give us the answer how much more selective you have to be already. Atrasentan is already selective enough to prevent fluid retention.
Now, one of the other side effects that we worry about with endothelin antagonists are hepatotoxicity or liver toxicity. Is there any difference in having an ETA versus ETB in causing liver toxicity, or do we understand and know how that side effect occurs?
Well, that is not directly related to the endothelin A or endothelin B type receptor inhibition. That is mostly related to the type of the molecule. The earlier endothelin receptor antagonists had such a molecular structure that they could directly target the liver and could lead to liver injury. The more recent endothelin receptor antagonists, including sparsentan, but also atrasentan, but also this drug, does not show any sign of liver toxicity or elevations in liver enzymes. So I think that we can be reassured that will not happen either with atrasentan 6.2 or with sparsentan. The risk appears also to be very low, despite there is a warning signal
So
for
the
sparsentan.
so the earlier observations were with bosentan, a drug that is commonly used for pulmonary hypertension, was really an effect not of the class of drugs, but actually the molecular structure.
And we know sitaxantan, which was withdrawn because of liver toxicity, which was also one of the earlier endothelin receptor antagonists. But with the recent ones that are tested for chronic kidney disease, we don't see these liver enzyme elevations.
Okay, one last question before we get into the trial, and that is, what is the evidence surrounding endothelin in IgA nephropathy?
Yeah, there's accumulating evidence that endothelin plays a crucial role, not only in IgA nephropathy, but actually in many chronic kidney diseases. And we know actually from somewhat older studies from the 90s that monocytes of patients with IgA nephropathy have increased endothelin 1 concentrations. Kidney biopsies of patients with IgA nephropathy have demonstrated that endothelin 1 is elevated. So there is indeed human evidence that endothelin is involved and contributes to kidney disease progression in IgA nephropathy.
Now we move to the trial, and so I want to give you a sort of a platform here to talk about this trial designed and where was it done, and kind of what the inclusion-exclusion criteria was for 6.2.
So this was a phase 2b clinical trial. It was a dose-finding trial to assess optimal doses for proteinuria lowering in patients with IgA nephropathy. The trial enrolled adult patients with a GFR above 30 and a urinary protein to creatinine ratio more than 750 milligram per gram creatinine, who were already using a maximum tolerated dose of an ACE inhibitor or angiotensin receptor blocker. SGLT2 inhibitors were allowed as long as the dose of these SGLT2 inhibitors was stable for at least 8 weeks. Patients with moderate or severe edema within 6 months of the study were excluded, as were patients who were using immunosuppressive therapy. And then eligible patients were randomized to placebo, to drug 6.2 at 3 different doses, 5, 10, or 20 milligrams. So basically you had 4 treatment arms, 3 with different doses of the drugs, 5, 10, and 20 milligrams, or placebo. These patients were treated for 24 weeks. The primary endpoint was the change in urinary protein creatinine ratio at week 12. And then the secondary endpoint was the change at week 24. At the end of the study, patients proceeded to a 4 weeks washout period to assess safety. The study was done in 32 clinical practice centers in China and enrolled overall 131 patients, so about 32 patients per treatment arm, which is a reasonably sized phase 2b clinical study in IgA nephropathy and thus had sufficient power to assess effects on urinary protein creatinine ratio. The baseline characteristics showed that the average patient had a GFR of around 70 mL per minute and a 24-hour urinary protein to creatinine ratio, UPCR, was 1.1 milligram per gram creatinine. Interestingly, about 50% of the patients were using an SGLT2 inhibitor at baseline. So this is the highest the use of SGLT2 inhibition I've seen in a clinical trial so far.
Yeah,
And these are all,
I usually it's in the 20% range in the more
yeah,
contemporary, so
yeah.
50% is quite a lot.
Yeah. So, and the follow-up was also extremely good. I mentioned the study was done only in China, in 31 clinical practice sites in China. Follow-up was excellent. Very few patients discontinued the drug or discontinued study. Adherence was excellent, more than 95%. So after 12 weeks of treatment, there was a clear effect of the drug on proteinuria. The reduction in proteinuria ranged between 34 and 48% with the drug, 48% achieved with the highest dose, and about 19% with placebo. So the placebo subtracted difference was 38% urinary protein creatinine ratio difference with the highest dose, which is a very clear effect.
Well, one of the things I want to go through here is that when you design the trial or your group designed the trial, usually you look at a benchmark of about a 30% reduction in proteinuria, and you exceeded that in each of the doses. Is that correct?
Yeah, each of the doses showed more than 30% reduction in urinary protein creatinine ratio from baseline. And of course, then the question is, which dose do you take, right? If all these doses are already so effective, which is the best dose? And that, of course, depends then also on the efficacy safety balance. You have to find, because I believe that many endothelin receptor antagonists, as long as you dose them high enough, they will reduce proteinuria. But the challenge we know from the past is to find that sweet spot where you have maximal albuminuria reduction and minimal side effects, i.e. minimal fluid retention.
How is the drug cleared by the body?
Yeah, mostly cleared via the liver, so metabolized and then excreted, and minimal clearance with urinary or renal clearance.
So that means there's not going to be a lot of dose adjustments based on kidney
No
function.
dose adjustments required. No.
Before we move on to the adverse effects, and thank you for presenting the proteinuria reduction. It looks like there were some steps that were taken by the group to diminish the side effect of volume retention. For instance, you measured beta natriuretic peptides. You had to have a lower level of those, and then the second was that you had to excluded those individuals that had a history of heart failure. Can you describe how that was done and how that might affect the interpretation of the adverse events?
Yeah, of course, we know from the past that this drug may induce heart failure, in particular in people at risk of heart failure. So therefore, just like other clinical trials that are testing this endothelin receptor antagonist class, patients with heart failure, New York Heart Association class 3 and 4 were excluded. Patients with moderate or severe edema within 6 months of study entry were excluded. Patients with NT-proBNP levels more than 600 were excluded. Well, I can tell you that many patients with IgA nephropathy do not have heart failure class 3 or 4. Many don't have an NT-proBNP above 600. Many won't have severe edema within 6 months. So that's why this drug class is so good for patients with IgA nephropathy because of the inherent low risk for heart failure. The story is completely different in diabetic kidney disease, of course. And we previously tried this drug class in diabetic kidney disease, and diabetes by itself has already increasing the risk of heart failure. So these patients are much more prone to develop heart failure with an endothelin receptor antagonist.
Let's just go ahead and talk about the adverse events. What was seen across the different doses and the placebo for this trial?
Yeah, so when we look at the adverse event, we see that overall, all the adverse events were similar between the placebo group and the 3 doses. So treatment emerging adverse events were similar in proportion. The serious adverse events were rare, one patient per treatment arm, and also in placebo, one patient. So low risk in general. If you then look at the adverse events that most often occurred, interestingly, upper respiratory tract infections, and we still don't understand why that is, but that occurred numerically more often in the highest dose. To be precise, 10 patients in the highest dose and 3 patients on placebo. So these are still small numbers we are looking at, and it could also be a chance finding, but that appears to be small imbalance. Then there's anemia occurring more frequently with the drug, and we see that in other endothelin receptor antagonist trials as well. That is probably reflecting dilutional anemia. So it's probably still a small effect on vascular dilation. And then when we look at peripheral edema, there were 5 patients in the placebo group with reported peripheral edema by the investigators. And then 2 in the low dose, 1 in the middle dose, 10 milligram, and 1 in the high dose group. So peripheral edema did not occur more frequently with the drug. If you look at the body weight and NT-proBNP changes over time, no difference whatsoever between the placebo and any of the dose groups in body weight changes or NT-proBNP level changes over time. Already telling you that this drug in this population does not impact fluid retention. There was still some anemia, and we have to further investigate this. I have the impression that endothelin receptor antagonists may directly affect EPO. So we are currently measuring EPO levels in our laboratories to find out if there's a direct effect on EPO.
You had already mentioned before about the liver function studies. Can you again reiterate what was seen in that?
Yeah, so we looked at liver enzymes and elevations in liver enzymes. There were 3 patients who had an increase in ALT in the placebo group and 1 in each of the dose groups with 6.2. So here again, a signal that shows us that there is no increase in liver enzymes with the drug.
It's widely known that endothelin 1 is the most potent vasoconstrictor in the body. And so blocking this results in lower blood pressure. How much blood pressure effect did you see across doses? And then did you see any side effects of hypotension?
Yeah, so interestingly, there was not a clear reduction in blood pressure in the population. When you look at the blood pressure changes over time, they fluctuated, and we could not discern a clear signal, a modest reduction of about 2 or 3 millimeter mercury systolic with the drug. If you look at the other endothelin receptor trials, like PROTECT in IgA nephropathy or like ALIGN, you'll see that there's also not a clear effect on blood pressure. And maybe this is because we are testing a dose that is very low, and still a low dose gives you the albuminuria reduction. But to see an effect on blood pressure, you need a higher dose. And we know that there is now one endothelin receptor antagonist registered in the US and in Europe for the treatment of resistant hypertension, aprocitentan. But that has a relatively high dose, 12.5 and 25 milligram, tested, of course, in patients with resistant hypertension. So maybe the dose response curve is dissociated from the albuminuria dose response curve for an endothelin receptor antagonist.
Well, that's very interesting. The last discussion point I wanted to bring up is the change in EGFR. I know the study wasn't powered for that and wasn't long enough to really be able to detect it, but obviously you're going to show the data for that. What did y'all find for the EGFR?
Yeah, we always believe that endothelin receptor antagonists, because of their allegedly blood pressure lowering effects, have hemodynamic effects on the kidney and will directly reduce to a reduction in GFR, just like we've seen with SGLT2 inhibitors or ACE inhibitors. But actually, if you look at the EGFR data, at least in this study, there was no acute reduction in GFR. Actually, the GFR fell a little bit more in the placebo group, 4 mils per minute, compared to about 2 mils per minute with the active drug. Now, this is again a signal that has been seen in PROTECT as well, that there is not a clear signal or acute effect of an endothelin receptor antagonist, at most about 1 mil per minute. We've seen it with atrasentan as well, not a clear signal on estimated GFR, both in patients with diabetic kidney disease as well as in patients with IgA nephropathy. So my conclusion is there's probably a hemodynamic effect, but a small effect, and definitely smaller than what we know with SGLT2 inhibitors. And of course, this study had only 24 weeks in duration, so we cannot look at eGFR decline in the long term. For that, we need additional studies, longer studies in larger population.
Given that half of the patients were on SGLT2 inhibitors, you have a unique opportunity to look at the effect of SGLT2 inhibitor on albuminuria reduction. What did that show?
So there were about 16 patients in each treatment arm that were on an SGLT2 inhibitor, and the effects were consistent. So whether or not you were using an SGLT2 inhibitor, you still see that remarkable and profound reduction in UPCR. And that tells you that these drugs can be given together. And the beauty is, but again, the study was too small to test this hypothesis, that because of the diuretic effects of SGLT2 inhibitors, adding an endothelin receptor antagonist to an SGLT2 inhibitor is a very interesting approach, because you can probably mitigate the fluid retaining effects of an endothelin receptor antagonist if present by the SGLT2 inhibitor. And that's a hypothesis currently being investigated in the Zenith trial, a large clinical trial in 1,500 patients with chronic kidney disease.
Do you see the future of IgA nephropathy having standard background therapy of renin-angiotensin system inhibition, SGLT2 inhibitor, and then endothelin antagonism? Is that where we're headed?
I find this future extremely exciting, because I have no idea where we are heading to. Are we going to give these drugs to all patients? Or are we going towards stratifying patients based on their molecular profile? I hope the latter. I know this is an area of active research by many, many people, and I hope we are able to develop and to identify biomarkers that can be easily measured and then stratify the patient. So a patient with high endothelin activity gets an endothelin receptor antagonist. A patient with an immunostimulative profile gets an immunosuppressive agent. That would be the hope, and that would be an ideal future from my perspective.
Now, lastly, is a phase 3 trial ongoing or planned?
Definitely in consideration, and that's all I can say. But with these results, you have to move forward and start thinking about a phase 3 trial. And I hope to be back in a couple of years and presenting a phase 3 result.
Well, thank you so much for this presentation, and also congratulations to you and your group on really moving the field forward with IgA nephropathy. Again, this is a late-breaking clinical trial here at ASN Kidney Week in San Diego, California. Thank you so much for joining us.
Thank you for having me, and I wish everyone a very nice conference.
We have Dr. Richard Lafayette from Stanford University, and he'll be talking about the long-term results of an open-label extension study of atacicept for the treatment of IgA nephropathy. This paper will be published simultaneously in the Journal of the American Society of Nephrology. Jason, welcome to the podcast.
Yeah, hi, Matt. It's my great pleasure to be with you today.
Well, again, we're in the IgA renaissance, and we're our third simultaneous publication in Jason. This one is an open extension of a phase 2b study that has already been published and completed. Can you tell us first, what is atacicept?
Yeah, it's a great question. So atacicept is a fusion protein. So it's basically the active part of an antibody, the Fc receptor, taken together with the cell receptor, which is called TACI. And so TACI is an innate B cell receptor for cytokines that in turn drive B cell proliferation and ultimately plasma cell survival. So by giving TACI with a antibody Fc receptor, you could actually clear out ligands for that receptor from the circulation. And since TACI is fairly specific for BAFF and APRIL, powerful cytokines that stimulate the B cell development and plasma cell survival, you can deplete BAFF and APRIL from the blood with this fusion protein and get very impactful BAFF and APRIL inhibition.
This is a pathway that's important for all B cells and plasma cells. Is that correct?
Yes, this is sort of universal, although the combination of BAFF and APRIL are particularly important in class switching. So that's another mechanism through the TACI receptor that sort of premature early B cells have to determine if they're becoming IgG or IgM or IgA antibody cells. And in the right context, particularly in mucosal surfaces, the presence of BAFF and APRIL allow for class switching to become IgA antibody specific as opposed to IgG specific. So it is universal and it will affect all B cells, but it has a slightly greater target towards early responses, so for IgM, and then for mucosal responses with IgA.
Well, this targets both BAFF and APRIL, and I want to compare and contrast this to another drug that targets APRIL, and that's sibeprenlimab.
Yeah.
I think I said that right.
Yeah, so sibeprenlimab is different, as is other anti-APRILs, because that's just a monoclonal antibody that directly recognizes as a ligand APRIL, and so it depletes APRIL by that specific technique of using a monoclonal antibody, grabbing APRIL and making it not available to get to its receptor.
Now, this is a fusion protein, the drug we're talking about, atacicept. How do you administer that drug to patients?
Yeah, it has to be given subcutaneously because it'd otherwise be degraded by gastric acid. So it's given subcutaneously. In this trial, it was given every week as a small 1 ml shot. And patients would get their medicine every week, and they were able to take that at home.
Now, before we get to the extension phase, let's first talk about the phase 2B trial that was published in Kidney International. What was the name of the trial, and just briefly summarize what was done and what the results were for that study?
So this is the Argin 2 trial. And so this is a phase 2 trial looking at the safety and efficacy of atacicept in patients with IgA nephropathy. So the study design was that it takes at-risk patients with biopsy-proven IgA nephropathy at any time who've got a GFR greater than 30 mils per minute and then greater than 1 gram per gram of a protein to creatinine ratio or greater than 1 gram per day of protein. And they have to be well controlled on their RAS inhibitors for at least 90 days and have their docs and investigator team feel that was the max tolerated dose. And then patients could be randomized to atacicept or an equivalent placebo, and they were followed for 9 months, with the primary outcome being 6-month proteinuria, and then secondary outcomes being 9-month proteinuria, 9-month change in GFR. And then at 9 months, all patients were offered open label atacicept and allowed to continue on drug out to 92 weeks, where safety was continuously monitored. And again, further outcomes of long-term control of proteinuria and long-term changes in GFR were monitored. So in the first part of the study, the placebo part out to 9 months, as you said, we published in Kidney International that the drug was well tolerated. You really could not discern the patients who were on various doses of atacicept because there were 3 doses in this phase 2 trial from 25, 75, and 150 milligrams. And then after 9 months, everybody went on 150 milligrams of weekly atacicept. But during that placebo-controlled group, there were the 3 groups on meds compared to the placebo patients. And again, the 3 doses were all well tolerated. You couldn't tell the difference between them for safety or compared to placebo. The main issue was just injection site reactions of a little redness and swelling. And then the 6-month data did show a significant difference in proteinuria between the atacicept groups and placebo, where there was a net change of about 30% at that point, and that was further extended at 9 months, where the proteinuria relatively was still down more than a third compared to the placebo group. So the drug was effective at lowering proteinuria. It was well tolerated. And then through the Kidney International 9-month placebo phase, we could see that the GFR was stable. There was a substantial reduction in proteinuria in the placebo group, but there was actually no loss of kidney function in the patients taking atacicept. So it was very impressive at that point, but the importance of going now further from 9 months to nearly 2 years was to further establish safety, see if that proteinuria could be reduced in a continuous way, and if the GFR would stay stable.
Well, that's really impressive results. And one thing I think you mentioned is that you saw similar reductions in proteinuria on the 3 doses, really no difference at all. Is that correct?
No, so to be clear, there was some dose dependency. So there was good safety, is what I was saying. There's no difference in safety between the groups, but the 75 and 150 milligram groups did do better than the 25 milligrams. And the choice was to go forward with 150 milligrams because it was well tolerated. And there were other biomarkers in the study as well. Most importantly, the drug, by affecting the TACI receptor and reducing BAFF and APRIL, has a very profound effect on systemic IgA levels and equally to galactose deficient IgA. So the most rapid and best reduction of the galactose deficient IgA was seen in the 150 milligram dose, together with solid reduction of proteinuria. And that's why that was chosen to be the dose in the extension period that everyone moved to from the other doses and from the placebo group. So it was a little bit more effective at reducing galactose deficient IgA and was as good as any for reducing proteinuria and stabilizing GFR.
Just to reiterate, one safety profile was similar for all 3 doses. However, you did see a dose response to the proteinuria, more so in the 75 and 150, but also some of the biomarkers, like you mentioned. I think that's also a really cool strength of this study, is to see the actual reduction of galactose deficient IgA. Just curious about that key point. Has any other therapy been shown to reduce those levels like this drug does?
Yeah, so just looking back at sort of the competitive space, the hemodynamically active drugs don't seem to have any impact on galactose deficient IgA, so RAS inhibitors and endothelin blockers, although there's not much formal measurements of those, but it's not thought to impact that. Systemic corticosteroids, there's been some small trials suggesting some impact, but at least word of mouth, which is all we have right now, suggests that in the testing study there was no impact on galactose deficient IgA. Tarpeo does have a significant effect, but it's relatively minor. It's somewhere in the 5 to 10%, but statistically significant reduction in galactose deficient IgA. And then these agents are most effective, reducing it by about 60%. The APRIL monoclonals are in the same neighborhood. So the BAFF-APRIL drugs and the anti-APRIL drugs seem to have a very profound sustained effect on reducing IgA and galactose deficient IgA. And there's early data on anti-plasma cell agents like anti-CD38 monoclonal antibodies that have shown about a 30% reduction in galactose deficient IgA.
And I see from looking at the data, IgM seems to be impacted the most.
So these agents do have a powerful impact on IgM levels. And remember, IgM is sort of your early phase response to vaccines or to infections, and then you sort of sustain that memory response with IgG, and IgG seems to be the most important. So there is a sort of 80 or greater reduction, 80% reduction in IgM levels, about a 20 to 30% reduction in IgG levels. But again, throughout the development of atacicept over the last decade, that's associated with sort of great safety, freedom from serious infections, and the hallmarks of both the anti-BAFF-APRIL and the anti-APRILs to have relatively significant sustained but well-tolerated impacts across these antibodies.
Now let's move on to the study that you're presenting, and it's an extension. So let's talk about how that was done. You've already mentioned that your group chose the 150 milligram atacicept dose. So how did you go about doing this part of the trial?
Again, this was something that patients knew would be offered to them at the conclusion of the double-blind dose finding part of the phase 2 study. So patients were then sort of just offered the opportunity to continue with their consent, continue on in the study, and virtually all the patients did. We had more than 90% of patients stay in the study, which is great. So we have more than 100 patients still going forward on drug to do the extension study. And so patients were just offered to continue. And if they continued, everybody's doses was adjusted to the 150 milligrams sub-QQ week. And as I said, patients pretty universally accepted it, which was great. And then their biomarkers were followed, the galactose-deficient IgA for safety, all their antibody levels, and their proteinuria and GFR, galactose-deficient IgA were all tracked. And one other interesting thing was their hematuria was tracked. Because again, more than half these patients had hematuria at baseline. And during the double blind period, the majority of patients with atacicept cleared their hematuria, and virtually none of the placebo patients did. So hematuria was also tracked during the remainder of the study to see how those placebo patients would do in converting in terms of their proteinuria, GFR, galactose-deficient IgA, and hematuria.
Well, that's also something we're starting to see with the careful measurement of hematuria. And what other drugs that are currently investigation are also lowering hematuria? And is this degree of efficacy more or less than what's been observed previously?
Yeah, so for steroids and systemic steroids, it hasn't been very well reported. However, for patients with Nefecon with targeted budesonide, there is evidence that hematuria is improved. In the anti-APRIL program, there was sort of a post hoc analysis where also it looks like hematuria is improving. So these drugs that work upstream look to be really, really promising and influential, where not only do they lower proteinuria, but they are able to lower galactose-deficient IgA, hematuria, and as we'll discuss, really nicely stabilize GFR. So again, mechanistically looking very good, reducing prognostic measures of the galactose-deficient IgA, of the proteinuria and the hematuria, and at least over the short term, resulting in stabilization of the kidney function.
So, looking at some of the figures, what you've done is you've taken the randomized control period, and all those patients who received atacicept are included, and then those that were on placebo that then in the extension phase got atacicept were then kind of put back at day zero and tracked as well. Is that sort of how this is
Correct.
done?
Correct. So we have the full nearly 2-year data on all the dosed patients from their very first day of getting atacicept. And then since the placebo patients then start receiving from 9 months, we follow them from 9 months to 92 weeks, and their data is added on. So all the changes in proteinuria represent all those patients for the placebo group from 9 months to 92 weeks, and for everybody else from day 0 through 92 weeks. Correct.
In figure 5 is the estimated GFR, and that's almost 2 years of data right there, 96 weeks, and appears to barely change. Is that right?
Yeah, it's really nearly astounding, because this is really what we say we want to do for our patients, is lock in their GFR, keep them absolutely stable. And this really is the strength of this observation, that this is the longest term data in IgA nephropathy at all with any therapy, and with atacicept to take patients to 92 weeks and really have a GFR progression rate of less than 1 mil per minute per year. It's really phenomenal.
Less than 1 sloping GFR. I've not seen that before.
It's what makes us really, really excited. And to see that sustained through this period is just wonderful. And to have the ongoing control of hematuria, where very few patients had residual hematuria by 92 weeks, where the proteinuria is very, very well controlled because there was a continuous reduction compared to what we had seen, where the proteinuria is now down by more than 40% from baseline. And to see that sustained safe tolerability of keeping the galactose deficient IgA down now at 92 weeks around 2/3 reduction without significant infections, major adverse events, it really makes you feel, wow, this is super exciting.
Totally agree. So the phase 3 trial is currently ongoing.
Correct.
Now, the nephrology community looks at the addition of these immunomodulatory agents. There is some hesitation, especially in something that these patients will be taking. My guess is potentially lifelong. Is that right?
Yeah, correct. The present plan is that this is a lifelong disease where you're genetically predisposed when you make IgA. We've seen some hints with atacicept and with anti-APRIL drugs that when you stop the drugs, the galactose-deficient IgA does come back towards baseline. So the initial idea would be that this could be a lifetime intervention to keep the GFR stable and prevent complications of disease. So we do have to think about safety very, very seriously and try to be sure that we're achieving what we want, is that a well-tolerated, safe therapy, again, can tolerate a little bit of adverse events in terms of protecting the kidney from going to dialysis, but we want to make sure it's safe long term.
And what about if a patient does have an infection or wants to undergo vaccination? Would you discontinue the drug for a short period of time? How do you envision that?
Yeah, right now, again, it seems very clear, and there's good evidence because patients have been treated for variable time with this agent for IgA, for other conditions like lupus and rheumatoid arthritis. So there's more than 1,500 patients who've experienced the drug for various times, and we've looked at immunization responses, and your immunization memory is well preserved. Again, there's low number of patients where you can get immunized on the therapy and get antibody responses. So it looks like that is preserved. As I mentioned, infections seem to be rare. The IgG levels tend to stay in an acceptable range, but if someone got a severe infection, we would certainly want to look and make sure they don't have hypogammaglobulinemia. We would probably want to hold the medication during the severe infection. If they had hypogammaglobulinemia and it was life-threatening, you'd have to consider giving some intravenous immunoglobulin. But again, that has not been seen in these 1,500 patients to date. So I think we're on pretty safe ground. And there's always a lot of competition between different BAFF-APRIL drugs, different anti-APRIL drugs. But the beauty is that the story together is one of safety and still of efficacy, despite reducing IgG a little bit and IgA in a big way. So it all builds on one another to think that this is something we'll be able to safely use. And if we can get these kinds of impact on kidney function, I think we're really going to adopt it nicely.
Now, is this something that would supplant the use of steroids?
Yeah, I absolutely hope so. I think the steroid days should be over. I've been trying to champion that for years already, that the benefits of steroids really barely exceed the risks. And now that we do have accepted drugs already in that target complement that are more targeted to the gut for lower steroid exposure, better hemodynamic therapy, I already feel people should not be using systemic corticosteroids for IgA nephropathy. And I'm not talking about RPGN, but outside of that, I really don't feel that we should be using systemic corticosteroids anymore, especially in places in the world where we have access to these newer agents. And I think that when we have atacicept, that will be even more so true.
What about the use of budesonide? Will it supplant that?
It'll certainly be a very competitive program because we have not yet established the safety of recurrent doses of budesonide, of targeted budesonide. We sort of have 9-month exposure to budesonide, clearly showing an antiproteinuric and a GFR stabilizing effect, even for a year and a half afterwards. But there are signs that the galactose-deficient IgA is returning, the proteinuria is returning. So we'll have to examine the safety of doing repeated dosing of targeted budesonide. So we already are seeing that in the phase 2 program with atacicept and hope to be able to, again, recreate that in phase 3.
Well, these are very exciting results and can't wait to see the results of Origin 3. Any idea about when that might be completed?
Well, all I can say is soon as possible. It's recruiting very, very nicely. And, before too much time goes by, we certainly hope to have at least the Part A results, because as in other studies, we have to recruit a couple hundred patients to get the proteinuria impact and see how they do with 9 months of therapy. And then we can go to the FDA, or I should say part of the study team, but the company can go to the FDA and hopefully get approval so that we practitioners and our patients will have the agent as soon as possible.
And I also liked how it's administered subcutaneously, much easier for patients. And, if you've been by any infusion centers, you see it's just no room. And so having an agent that can be administered at home, I think would be welcome for patients as well. Is there any other diseases that this agent is being tried on?
So it's very early days, but again, I think there's great enthusiasm that because of the tolerability, that there's really for other antibody-driven diseases like lupus nephritis, like membranous nephropathy, maybe in some of our primary FSGS minimal change patients who may be antinephrin based, there really may be super opportunities in the near term to test these.
Well, thank you so much for coming, and congratulations to you and your team for this paper and this advancement in the field. And thanks to all the listeners. We hope you have a great ASN Kidney Week, and thank you so much for joining us.
Wonderful talking to you. Thank you.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.